Pen or something. And good morning, everybody. This is Dr. Gabriele Jasper MD, interventional pain doc, and I'm here on our podcast, Painless with Dr. Jasper. We got Jeremy here today helping us out.
Hey
He
guys.
sets everything up, and hopefully we got more people, more audience today. Now, I just want to put it out there that if anybody has any questions, because I'm going to have a kind of a comprehensive course today on the basics of what we do in interventional pain, which means that we really try to isolate the as far as my definition of interventional pain is try to isolate the pain generator and get rid of it.
Right.
Another goal we have is avoid any major unnecessary spine surgery.
Right.
There's a lot of unnecessary spine surgery being done, but there's a lot of good spine surgery being done.
So for those of you who only watch us on or listen to us on podcast, it might behoove you to go to Jasper Spine Institute on Facebook, where you can find this show archived, and you'll be able to see the visual aids that Dr. Jasper uses when he's discussing stuff.
Yeah, I'm gonna talk about the basics of what we do in interventional pain and what most pain doctors do. I'm going to talk about the new procedures and the outcomes of the new procedures, especially our endoscopic surgery that I've been doing probably for 18 or more years.
Yeah, that's a life changer, that one.
And I kind of cut back a little bit because of the new procedures, but it's picking up again.
Yeah, we got Dave. He says, Dr. Gabe, the best pain management doctor ever.
David Patnoid, haven't seen you in a long time. All right, so and I'm really going to talk about, I did a little bit more research. I'm not anybody that's going to pretend to be an expert in insurance, in Medicare Advantage, traditional Medicare versus Medicare Advantage, and also just your plain old, younger people programs that they sell, private insurance.
Yeah.
I'm not an expert, but I'm very, very upset about what's going on today with this Advantage. And it's going to come to a head. There's definitely going to be a class action soon. And we'll talk about that later. But first, I want to talk about some of the things that we do in interventional pain. If anybody wants to call in, you know the number?
Yeah, the number is 732-237-4949. You can call us here in the studio if you have any questions about what Dr. Jasper's talking about, and you'll be piped right in.
Any type of questions about, I try to answer about the Medicare with the supplemental, which is traditional old school Medicare versus Medicare Advantage or disadvantage, I call it. But anyway, we do the basic epidural injections.
Yeah.
Epidural injections are not a Band-Aid. They could be a prerequisite for insurance companies. They won't let you do anything else unless you've failed epidurals. And, I don't agree a lot on what insurance companies say, but I don't think anybody should operate on a patient. No doctor should operate on a patient unless they have received an epidural. That I have to say, because epidurals surprisingly do well in a lot of patients, probably the majority of patients. And by the way, I always say 80% of the people that have pain, back pain, sciatica pain, goes away on its own anyway.
Yeah.
You rest, get in positions where it doesn't hurt, and eventually it goes away. For example, I have patients that come to my office with severe pain. They have no MRIs. I can't do anything.
Yeah.
I tell them to take some anti-inflammatory stuff, but I send them for an MRI. By the time they come back, the majority of them feel better. We had like 2 or 3 patients shit like that yesterday. So there's no rush into doing anything at all.
Right.
But if you're in severe pain and you can isolate where the pain's coming from, you hone in on that and you get rid of the pain. For example, epidurals, there's different types of epidurals. There's epidurals that go intralaminarly. They come into the middle and the back, right? They go into the laminar space, which is this space right here. And then you got the epidurals that go along the nerves near the neuroforamina. It's called the transforaminal epidural, bathes these nerves. And then you can have an epidural, a caudal epidural, which is basically coming into the tailbone area. And a lot of doctors seem to do that. I don't do caudals anymore because they just don't work,
Right.
as far as I'm concerned. That's kind of a shotgun approach. It's an easy fix. And if the patient's young and has just a little bit of low back pain, it might work. But when you talk about somebody has pain with inflammation way above this area, it's not going to work that good. I don't care what they say.
Right.
But that's my opinion. There's doctors that do it. They come into my office every day.
That's based on like years of experience too. So
Yeah,
I mean,
I've been doing this for 27 years. So you know what? It's got to mean something.
Mm.
I could write my own book. I just don't have time to do it.
Yeah, that's right.
If I can find somebody who can follow me around,
You could write several books, Doc.
You know, I like to write a book on how to treat pain, Dr. Jasper's way. You know, a lot of people will not agree with it, but guess what? It works.
And doctors would buy it just to have a manual.
And you can ask a lot of my patients and a lot of employees that work for me, and employees that used to be my patients and are still my patients.
Yeah.
And you're sitting in front of me. But anyway, what I like to do is I like to do the transforaminal epidurals. They seem to work the best. Why? Because you always have a component of, you're doing it because something's inflamed. And what are you going to give them? You're going to give them an anti-inflammatory steroid,
right?
Steroid of your choice. There's cheap steroid medication you can buy and more expensive. There's steroids that work really well, but then the higher risks. But either way, not to get into the different types of steroids, I use good steroids.
Yeah,
that cost money. So usually you get what you pay for.
That's good to clarify though, because a lot of people, when they hear a shot, they get the wrong idea because they've had shots from somebody else and they just never work for them, you know?
Well, that's why I get two questions when people come to see me sometimes. They ask me, Doc, why are you going to do the same injection as the other doctor did?
Right.
And then the second question is, why did yours work and theirs did not?
Yeah.
And what's the answer to that? Technical skill and the medication that you use.
Yeah.
You have to be precise. You got to stick a needle right in this spot, but you pop into the epidural space. And if you don't pop into the epidural space, you go up here, somewhere down here, all over. If you don't get into that spot, it's not going to work.
Right.
I don't care what you're saying. Maybe a little medicine will get absorbed into the bloodstream through the soft tissue, and a little bit get there. You might feel a little bit better, but nothing's going to work as good as a direct hit right on the outside of the nerve, not in the nerve. You got to pop in the epidural space. And if you could notice that this nerve is swollen, this one isn't.
Right.
That's inflammation, swelling, and pain. That's what they have when they come in.
Yeah.
So I drop the medicine over there and it bathes this. Now, what's good about a transforaminal compared to what I think as far as the intralaminar, which go in the middle. See, the intralaminar injections, you got to remember, and a lot of people don't realize this, that in the central canal, there's either no pressure or negative pressure. Very rarely increased pressure. So if you put medicine in here and you got tightness around this nerve, it's a stricture here, it's stenosis, where it's tight and it's swollen, kinked. The medicine's going to go in the middle and it's going to go up and down. It's not going to bathe that nerve. And the sciatica pain is not going to go away.
Yeah.
But if you pop into the area right here at the transforaminal area, right, you have what they call as a cul-de-sac right here, which means that the epidural space ends right after the dorsal root ganglion, which is right in here. It ends right here. So you pop the medicine here, it fills up that epidural space, goes to this dead end here, increases the pressure, and that's sometimes the pain that the patient feels during an epidural, and it goes poof right into the middle, and it bathes the middle. So you're killing two birds with one stone with one injection. You get in the middle, and you get in that nerve that's inflamed, because you're always going to have some inflammation of the nerves in the middle, because that nerve goes in the middle too.
Right.
Central canal. And if you got central canal stenosis, you want to shrink these down in the middle. People give intralaminar epidurals for central canal stenosis, thinking that these nerves aren't inflamed either. But probably 95% of the time, this hole here is smaller too, because it's from the degenerative disc disease. This comes down, that hole goes from this big to this big or smaller, and they get pinched. Maybe you got a herniated disc like that. I mean, there's so many different things that can cause you to have that sciatica type pain.
Yeah.
But once this shrinks down to normal size, you have relatively more room because the nerve is half the size. That's an epidural in a nutshell. Now, I gave that comprehensive talk one time about everything's derived from the degenerative disc disease.
You can find that on our alcove.
Once this breaks
archives.
down, this disc breaks down.
Yeah.
That's the root of all evil, I call it. So that's your epidural. An epidural, we all do it. Might not all do it right. It might not all be as accurate. It might not all use the same medication. And that doesn't mean, I have people come in and they say, well, why is yours going to work?
Yeah.
I tell them, I said, it might not work. Epidurals will work sometimes and sometimes they will not. So you got to remember that the other good thing about our practice is the fact that I got a lot of stuff, a lot of tools in my tool shed. I mean, if you look at this counter here, I got all kinds of stuff. I got pictures. I got all kinds of instruments laying around over here. I mean, these are tools that I have in my tool shed, and the tool shed's getting bigger and bigger.
Yeah.
And they don't have a big enough tool shed at Home Depot. I got to get bigger and bigger storage rooms for the things that are coming out. And that's what I love about this field. It's an never-ending evolution of interventional pain.
Constantly evolving.
And it's infringing on a lot of other specialties. And they are not very happy about it. But that's okay. They always have the option
to
learn, and I'll teach them.
Yeah.
Because the Hippocratic Oath says you need to teach people what you know.
Pass on what you
can't give everybody the treatment by yourself.
Yeah.
You got to propagate it throughout the world. And that's what I do. I enjoy teaching.
Yeah.
So that's the epidural. Another simple thing that we do, and some of the doctor came to my office and says, yeah, I do the bread and butter stuff. Bread and butter stuff, I guess it's something that they're simple, been working for years, and they don't go advanced to the other stuff.
Right.
And they're happy with it and make a good living, probably a better living, because you're never gonna do the stuff that the surgeons to avoid sending them to big surgery.
Right.
So a lot of those guys end up sending them to surgery. They do the surgery, and hopefully they send them to surgeons that know how to do the new minimally invasive stuff. If they do, perfect.
Oh, we got.
If they don't, I could teach them.
Michelle Volpe, is it? Volpe? She says, Gabe, Sonny needs you again.
Oh, yeah, come on over.
Yeah. You're ready.
Now, another bread and butter, in quotations, is a procedure that, because of degenerative disc disease, this used to be like this, common denominator, but now it's like that. We get arthritis back here. These joints in the back here, see them moving back here? These joints, usually they're separated with cartilage in between. However, over years with degenerative disc disease, that breaks down, this breaks down, becomes bone on bone, and that hurts.
Right.
Most of the time it hurts in the morning when you get up because it's stagnant all night. Your body tends in the sleep, get in a position where it doesn't hurt. Otherwise you won't sleep.
Right.
Or it hurts less. But then when you get up, this starts to crunch and it hurts. People get up. Some people say it's like a ceremony. I get up in the morning. Some people say that I have to have my wife or my husband bring me a medication, right? Give me a massage, put some heat on it before they even get out of bed.
Yeah.
These are the people that have a lot of pain in the morning. These are the people who sit down, and after sitting down for a long period of time, which basically opens up those joints, and they stand up and they feel that, they got that pain when they get up, and they're kind of bent over, and they kind of ease it, and they start walking. As they're walking, it starts to go away.
Right.
Compared to when you start walking, it feels good. And then after you walk for a while, you start to develop the pain in the low back and buttocks. That's a differential diagnosis for spinal stenosis.
Right.
Those are the people with spinal stenosis. Can't walk far. Usually people with arthritis, when they start to walk, it hurts. Then it loosens up. But if they really walk far, it starts to hurt again. These are the people who lean in the mirror to put their makeup on or shave. And when they're leaning over, the body tends to pull her muscles back and then crunch these.
Yeah.
That's how you make a diagnosis with that. And how do we get rid of that? In the groove here, which I don't see it in this groove, here's one right here. Right here, you see a black line there, right?
Yeah.
Right there's a black line. I drew that in as a nerve that comes out of the joint, goes into this groove, brings pain sensation to the brain. This is a procedure that I've been doing for over 20 years. I used to have a special needle, special tip. I put the tip there. I hook it up to a generator. and I heat that up at 80 degrees Celsius for 90 seconds. It stops it from working. I do it to you occasionally. You said you might need it soon.
Yeah, it's an amazing procedure.
And it gets rid of that nerve. Well, it doesn't get rid of the nerve. It denaturizes the protein. Like when you fry an egg, it goes from clear to white.
Right.
Well, when the protein are not normal proteins, they're denaturized, no electrical impulse will go through. Then it stops. You don't feel the pain from that joint. And they usually feel pretty good. They come back and say, Doc, I pop right out of bed in the morning and I don't have that pain. There's no longer a traditional ceremony that I have to go through in order to get out of bed.
I've said that to you. Yeah. Because it is magic. Like 2 weeks after I get my last, it's like somebody snapped their fingers and I can roll out of bed without a grunt. You know, it's amazing. Absolutely.
So that's two procedures that we do every day.
Yeah.
Another procedure that I've been doing for probably 20 years is a kyphoplasty. When you break this bone, it's probably one of the worst pains you can have in your life. You break this bone, it crunches, it hurts. And as soon as you stop the crunching, like when somebody breaks their arm, they put it in a cast, it doesn't hurt anymore because it's not moving.
Right.
But when this is crunching this bone, it's a compression fracture of a vertebral body. That happens mostly in the elderly women that have osteoporosis, osteopenia. They could just fall on their butt. One lady the other day said she did it by making her bed.
Oh, Jesus.
She was making her bed. Another lady did it carrying clothes up the stairs. But by the way, you need to treat that. You could treat that with medication, which changes it from osteoporosis, osteopenia back to normal bone or close to normal, where you have a higher risk of a less incidence of breaking a bone again.
Right. Now, this is what traditionally, layman's, I guess, referred to as a broken back.
Well, yeah, broken back, but broken back can mean a lot of things. It's usually when they got it and they get diagnosed, they know they have a compression fracture, and sometimes it comes in more than one. If they tend to break their back, compression fractures, it happens more often. And the way I treat that, if you notice that there's a bridge here between this bone, this bone, here's the bridge, and here's the outside of the pedicle. I stick a sort of an extra, a little bit larger than normal needle through there under X-ray, and I go through that bridge here, through the bridge into the vertebral body, and I deposit a cement, they call it. I call it a medical epoxy because we got to mix it like fiberglass or epoxy. And it fills the cracks under live X-ray to make sure it goes where it's supposed to go, make sure it doesn't go where it's not supposed to go.
Right.
Because you could have complications if it's not done right, just like any other procedure. And you could have a complication if you do everything right. You never know. But anyway, it fills up the cracks. It gets hard like bone. Pain goes away.
And it's like almost immediate, right?
Yeah, usually probably 90% of people that get off the table, they got no more pain. I had a patient Wednesday that came to see me, and she had a fracture a year ago, right?
Yeah.
No, it was about 8 months ago. She had a fracture. She comes to my office, still in pain. And this is why I give these talks on the podcasts. And I hope maybe somebody who is an ER physician or a physician today that work in the hospital as hospitalists, because this is a lady that lifted, fixed her bed, and she fractured her back. She couldn't move. She couldn't breathe. Family brought her to the emergency room. She goes into the emergency room, and they give her some pain medication, and they admit her to the hospital. They admit her to the hospital for 2 weeks. She sees everybody, including their brother, as a consult.
Right.
So who you can imagine who saw her. She said mostly the person who worked in the hospital, which is a hospitalist.
Right. And
all they did was they sent her to physical therapy, tortured her.
Wow.
And they gave her pain medication. She's still not healed up. She said they made her go. It was the worst thing she ever experienced. Right. I mean, you can't breathe, you can't walk, you can't cough, you can't sneeze, can't sing, can't do anything.
Yeah.
And you got the high incidence of getting, pulmonary embolus from a blood clot, pneumonia because you can't cough, you can't breathe, you can't, and and it just hurts. You know, you don't go anywhere.
And this
you
is
get atrophic.
This is like something that if you just leave it alone, it's not going to go away. I mean, it's
No. If you, first of all, it's very slow on a person that has osteoporosis.
Okay.
Because what is causing osteoporosis? The inability to maintain enough calcium in the bones.
Right.
So now you break your bone. Why? Because there's not enough calcium in there. How long you think calcium's going to go in there, build up, to fix it?
Yeah.
It's a negative effect to begin with.
Right.
I mean, you know, if you're a 25-year-old and you fall off a building, let's say you're on a scaffold, you fall off 3 stories and you land on your butt.
Right.
You're going to fracture your back, and they heal up generally about 6 weeks to 12 weeks because they're young.
Right.
And bones heal up. This lady is probably 8 months to a year out, and she came in with a fresh MRI. Somebody sent her for him, and it's still broken. She's still in pain. She says it's a little less painful. So when it's a little less painful, still, however, a pain score of about 8, 9. It's not a 10. You can still choose to treat it conservatively, but it's not a good idea if after 8 months or so or a year and it's still, you got to fix it.
Yeah.
And if somebody's old and can't get around, you fix it right away.
Right.
Because of all the side effects you can have for having, which I just talked about. And it's a very simple procedure, does not take long, and in the right hands, there's virtually no complication.
Michelle says he's like a crippled old man. LOL.
Who is?
Sonny.
Michelle said that?
Yeah.
What's the matter? You don't like Sonny? He just needs our help. That's what he needs.
That's what he needs.
Anyway, and so remember, you guys out there, you women, physicians or nurse practitioners or PAs, or even a nurse in the emergency room, when somebody has a compression fracture, get somebody to fix it.
Yeah.
It's called a kyphoplasty. Look it up. Very simple. I saw a show on TV, trauma show, where some kid got a trauma, and I saw the MRI. There was nothing loose. There's nothing dangerous of having any kind of complications as far as like paralysis. It was in an area where you do a kyphoplasty, they're done.
Right.
They opened the poor guy up and they did a fusion on him. That's still a little overkill and unnecessary.
Right.
You know, if it's unstable or something like that, then you can do it.
That's pretty cool. You can watch you can watch an old episode of Quincy, and they're showing an MRI of somebody's back, and you can diagnose it.
Did they have MRI machines during Quincy?
I think so. They're old and antiquated, though,
Yeah.
or they were, they were nightmare machines.
I don't think you're gonna have it on Perry Mason.
Dr. Kildare wouldn't have a MRI.
But yeah, so kyphoplasties are very easy to fix, and they're worth fixing. And that's 3 or 4 procedures that have been old procedures.
Yeah,
very well accepted in even the insurance company. They've been accepted, and there's no problems getting them paid. Now we talk about a new procedure here. We'll talk about the procedure where I have been giving sacroiliac joint injections, and there's so many people who suffer from sacroiliitis, inflammation of the sacroiliac joint. And now, what is a sacroiliac joint? If you look at this is the inside of the pelvis, right? You have the iliac crest, which is here, and you have the sacrum is here. So you have the sacroiliac joint.
Oh, okay.
See the joint right here?
Yeah.
Here's a joint. You can see it from the back too. Sacral iliac joint right there, both sides. Right? Here's the sacrum right there in the middle. Here's your sacrum. Here's a joint right over here. I've got backwards over here. I'm looking through the thing. I'm trying to move my finger. Right. Anyway, it's like doing endoscopic surgeries on lateral position. Well, what happens is you see this canal here.
Yeah.
Somebody's head got to go through there. When a woman is pregnant, right, the head's got to go through that canal.
Right.
And how does that happen? And that's why women have a higher incidence of sacroiliac joint problems, because during the pregnancy, they have hormones that come out into the bloodstream, and it loosens up the symphysis pubic
Right.
in the middle here. That loosens up and it widens. In other words, it can stretch, right? And it loosens up all the joints and ligaments in the sacroiliac joint, right? So this separates, because the sacroiliac joint is not like a a ball joint like your femur,
Right.
or your shoulder, or even joints like your fingers. They're not like that. This is a jaggered joint. It almost like fits in like a puzzle,
Oh.
and it's stable because it has a lot of ligaments that are ligatures that tie it in.
Right.
But when that gets all loose, especially if a woman has multiple children, not to say that men don't have this. Men can have this too for just having chronic arthritis,
Right.
and it starts. And a woman and not to say that women who don't have children don't have this.
But isn't it shaped differently in men? Like the whole area there?
Well, what's different about a man? That pelvic floor is a lot wider and open in a woman,
Okay.
and the pelvis. That's why women has more of an hourglass shape, because the pelvic is wider and shorter.
Gotcha.
The iliac crest in a woman, like this, looks more like a woman. A man's iliac crest can go up to here,
Right.
which makes it difficult to do some procedures in the spine because it's in your way, fluoroscopically.
Wow.
But what causes SI joint pain usually could be a trauma, right? That's a common reason, or it could be becomes loose, all these ligaments, and what happens over the years, this joint moves, it moves, and when it moves, just like the compression fracture, when it moves, when you got a fracture, it moves, it hurts. When this moves, it hurts. And you go into you could do certain procedures, certain provocative tests. We won't go into details, but you put them on the examining table, and you move their legs and their back and their pressure and this and that, and they have to have a certain amount of positive movements as far as a provocative test, and you can diagnose it that way. And usually the pain is in the lower back, right over the SI joint by palpation, right? And it's chronic. These are the people you give them epidurals, you treat the arthritis, you could treat the sacroiliac joint with injections. And that's the first line of defense. You stick a needle in right at the base here, where the opening is easier to get into, and you bathe it with a steroid. And probably the majority of people do well. Like if you have a bad shoulder, a bad knee, bad hip, you inject it with a steroid. Today, we're also injecting these things with regenerative medicine, like stem cell derivatives, stem cells. We inject it with PRP, platelet-rich plasma. Now, if that all fails, the conservative treatment, what do? The common denominator here, it's moving all the time, causing pain. We do a simple procedure, and it doesn't take long, very safe. And I hate to use the word fusion, because fusion in most people's ears, it's a bad thing.
Yeah.
But certain types of, even a big fusion of the back, if you need it, is a good thing, because then you're going to be much better.
Yeah.
You get it. Fusion in the back where you don't need it, most of the time you get worse. Well, you gotta pin this thing. You gotta pin it. And the way we do it is we make incisions, and I'm talking about an incision about an inch.
Right.
Maybe a little longer, a little bigger, a little shorter, depends on the company you use. And you see this screw right in here? It's a screw. And what it does is you put the screw in here, and they have specially designed screws. Once it goes through the joint, right? Once that screw goes through the joint, what it does is once it gets to its depth and you continue to screw, it squeezes the joint together. So it's a design that I don't think it's patented, but every company has a different design. But what they do is they in layman terms, they'll screw it, but you don't. It'll get to the point where if you have a space, as you keep screwing, it'll screw the joint together.
Yeah.
Right, and you can put some DBM in there. demineralized cortical bone that can help to do the fuse. Basically,
fusing,
why do you say fuse? Because it's stopping it from moving.
Yeah.
If you could stop it from moving, the pain goes away. I did the most recent one I had was a great woman that has a bad back and has bad arthritis. Beautiful woman, and she got 90% relief.
Really?
Over the years, I've been giving her SI joints once every 6 months. I bet you I don't have to give her any more SI joints. And it was only one side.
Yeah.
The other side still feels good. Hopefully she doesn't need it. But that's a game changer here. Very simple procedure. If somebody has been going to get, who's listening, who's been getting SI joint after SI joint injection and get good relief for a short period of time. Sometimes I got a patient now that I gave this. You need to do 2 SI joint as a diagnostic blocks. If 2 of them work, then they're a candidate. Of course, they got to fulfill. They got to have arthritis, and they got to fulfill the requirements. And part of the requirements, once you make the diagnosis, you got to do 2 diagnostic blocks. And once you do that, and they're positive, like a lady yesterday actually came in, and I gave her her second SI joint injection. The first one, she had complete pain relief for like 5 days. Then it came right back. And she's had multiple injections before by other doctors. And it just, same results. She's going to get a fusion of the SI joint, sacroiliac joint, and she's going to do well because we made the diagnosis. So this is something that we haven't been doing much. In fact, it's a relatively new procedure. I mean, they've been doing it for years, but now they've come, with the evolution and with the technology, they've come out with screws that are self-tapping.
Right.
You don't even have to drill a hole. Sometimes you do, sometimes you don't, depending on the system and depending on the physician.
This was the one you went away and learned about, right?
Well, yeah. You got to go away and learn about
it. Well,
anything,
yeah.
Anything new. Yeah. I learned
recently
from different companies, and we picked the best company that we think is going to do the best.
Yeah.
You don't even need much anesthesia. All you need is just sedation with local anesthetic.
Right.
It's not even near anything real dangerous. If you do it right, it's very safe.
It's magnificent. Safe. Yeah. That's fantastic.
Today's a chock full of new stuff. Because another thing, and by the way, I'm going to talk about my endoscopic at the end of this new stuff.
Yeah.
I'm going to talk about the endoscopic, and I hope some of the guys that, we have a new society. I don't know if anybody's here listening from the society, the Endoscopic Society. It's so new, I can't remember the exact word. I have to look it up and what it's called. It's Dr. Data.
Yeah.
Sudep Data. He's been organizing, putting it together. And I want to put a word out to him. He's one of the diehards that is still doing endoscopic surgery.
Yeah.
He's cuckoo like me.
Fighting the good fight.
Yeah. And we're going to keep hanging in there and doing it. And he's trying to revive it again. I've tried a bunch of times. And I said to myself, you know what? I'm just going to keep doing it. It's my business. I'm going to help my patients. But he's doing it, his business, help patients. But now I'm helping him. He wants my help, and a lot of guys throughout the world. We had a conference, a Zoom meeting the week before, and we had quite a few listeners and quite a few people talking. And Dr. Data presented it, and I gave my, he kept asking me what my opinion was. I gave my opinion. And we're just going to get better and better. Hopefully it gets out there and the insurance companies maybe start paying for it.
Yeah, that's awesome, Doc.
That would be nice.
Yeah.
Because it's tough. Today, we'll get into that later, but
sure.
Just stay tuned. Another thing I want to talk about, there's something in, if I had an MRI, I'd show you, but most people don't know what you're looking at anyway.
Right.
But if you look at an MRI, and I've been looking at it for years, I've been reading my own MRIs. I don't rely on the MRIs. Reports from the radiologists because they do a great job, but you get somebody with a bad back, they don't mention everything because they don't know where their pain is. They don't know the patient, so they talk about everything. When I look at it, I hone in on what this patient's problem is because I know where the pain is. I just did a complete history and physical examination on them.
Yeah.
And I've noticed over the years that these patients had what they call modic changes, where if you look at an MRI, somebody has degenerative disc disease, the inflammatory process of the degenerative disc disease kind of extends into this bone, and it becomes white on the T2 weighted image of an MRI. right along just outside of the end plate of these discs. You see a white, it could be one level, two levels, it could be the whole lumbar spine, even part of the thoracic spine. And I've always said that causes pain, because no matter what you do with a patient like that, you can't get rid of their pain. The pain that they have is, when I walk into my examining room and I see a patient standing, and I said, don't stand, you can sit down, you don't have to stand up for me. No, doc, I can't sit down. I got to stand. These are the people that feel better standing up. So guess what? It's not spinal stenosis. They might also have spinal stenosis. And if you treat the spinal stenosis, they always want to sit down. Now they don't want to sit down because they got pain standing up.
If I'm at a party and I see this guy and he's just looming over everybody, and I'll be like, dude, sit down. Like, no, I'm good. I'm like, you got back problems?
These are the people. Yeah. These are the people with modic changes. It's called vertebrogenic pain. The people who lean forward and it hurts. It's complete opposite of spinal stenosis.
Right.
The people who lean forward, it hurts. And they go into that category and they got modic changes. How do we fix this? Well, here's the vertebral biter that we talked about. Remember the compression fractures? I got one that you can actually see into it. And this is made by...
I was wondering what that was.
This is made by a company that I try not to mention companies, unless they pay me for it. No, then I have to disclose it.
Right.
But the procedure is called an intercept procedure. And you guys can look that up if you want to look at the company. But if you look at this, you see it looks like a spider in there, a yellow spider.
Yeah.
With a lot more legs than a normal spider.
Right.
Well, if you look the center of it, if you look at the center of that right here, that's the nucleus of the nerve. It's a nerve. It's called the basal vertebral nerve. Nobody really knew about this years ago because I insisted that they had pain. I would bring it up at the conferences, and you had mixed feelings about this, mixed comments about it, different schools of thought. But the majority said, nah, that doesn't cause modic changes, doesn't cause. We can't correlate it. Well, guess what? Somebody did. And they've done studies, and they've spent millions of dollars to get it approved by the FDA to fix this. You don't fix it. But like I told you about radio frequency lesioning, and you burn that nerve, and the pain goes away, you do the same thing with that basal vertebral nerve. But you got to get it just right in the middle. And where do you go? Just like a kyphoplasty. You go right through the pedicle because it's a bridge, and you got to get it right into the middle, maybe a little bit more posterior, a little less than 50% across, but dead center, right? And that's where the nerve is. And you heat that nerve up. You heat it up, it could be 7 minutes. If you're not quite exactly where it's supposed to be, you heat it up for maybe 15 minutes.
Okay.
14 minutes. And what that does, it denaturizes that nerve, and the nerve stops working and the pain goes away. I've had people come back after I do that procedure and said, Doc, I've had pain for 20 years. It is gone.
So you've been doing that one for a while.
Yeah. I mean, it's still relatively new in our practice.
Right.
It's been less than a year I've been doing housing.
Oh, okay.
Less than a year, maybe going on a year. And it's not like, people with spinal stenosis.
Yeah.
It's kind of like, people who sell their instruments and all the stuff from spinal stenosis, they're making a good living.
Right.
Because it's helping people, and a lot of people have it, especially in this area. This is kind of almost like, and this is my opinion based on my practice. You could have modic changes and no pain, right? When you have spinal stenosis, well, I can't say that. Some people have spinal stenosis and they still have no pain. But usually it's hard to really diagnose pain, vertebrogenic pain, in the beginning of the treatment because everything else hurts. And now we're talking about different pain generators.
Right.
Different pain generators. We got pain generators all over the place. There's no one shot going to get rid of it. Some people think so. They come in and say, Doc, you gave me that shot. And how come I'm only 10% better? Because that's only 10% of your pain.
Right.
the other percentage of your pain coming from other pain generators. We got to knock them out one at a time. They got this weird misconception that one shot will get rid of your pain. Yeah, maybe behind the ear. One shot behind the ear might get rid of your pain.
Yeah.
Maybe I'm not supposed to talk about that. Hey, this is a podcast. We can talk about anything.
Yeah, so we can talk about anything.
WLBM, they're gonna bleep that out or something.
They might. It's up to Paul. So yeah. So
we joke around like that, but it's true. I mean, you have a lot of pain, so you get rid of that, and now you just treat another person. And believe me, I have patients that all of these procedures that we have done so far and talked about, I have done on one patient, not one, but I'm saying many patients, but them all up to this point. Right. That's the intercept procedure.
I have degenerative disc disease and what have you. I wonder, maybe we should bring in my MRI. I can set a camera up to these lights, and we can hold it up.
Also do it digitally.
We could, yeah. I mean, there's ways to do it, and it'd be more, fun, I think.
Well, I mean, as I find out, I don't know if anybody's really listening, any physicians actually listening, but we could do a part of the program could be oriented toward physicians as a tutorial on how to read MRIs. We come in here and read MRIs one day.
Yeah, that'd be great.
Anyway,
everybody's agreeing that you're a great doc.
Oh yeah,
we got Rocco here.
Well, I hope nobody calls in and says I'm not. Can we get rid of that before it comes on the screen?
We can.
No wonder you get rid of it before it goes on the screen. I hate that son of a bitch. But then not too many people are complaining about waiting long anymore because we're getting it.
Oh no, you're like popping them out. Yeah.
Spinal stenosis. We alluded to that a little bit, and that has been around for a while. Treatment. I mean, spinal stenosis has been around forever.
Right.
But we used to just give them an intralaminar epidural, and if they didn't work, they go to surgeons. The surgeons should do laminectomies on them, hemilaminectomies.
Really?
Laminectomies, fusions, more fusions. And, they would do good in the beginning with that stuff. But as I said, there's somebody down in their basement trying to figure out how to make things better with less being done. And it's happening. And that's what we do.
Yeah.
That's what I do. Now, there's a procedure. It's called the mild procedure. We're talking about spinal stenosis. The main problem with spinal stenosis are people who sit down, they feel good because this opens up. They stand up, it collapses because they got a thick ligament. And that ligament, real quick, is like a leather belt. When you snap a leather belt, it makes that noise, and you put it together, it forms a loop, right? The ligament, when you stand up, this collapses, forms a loop, and it starts to rub all the nerves in the center because it's so thick. Why? Because of the degenerative disc disease. The discs, when they were big, the ligament was flat.
Right.
But when it gets down, standing up, it forms loop and rubs. So it's bunching of it. Too much ligament now because there's not enough disc.
Right.
So that's why we put the spacers in, they feel good. Because the spacers I put in prevent it from collapsing and that ligament stays flat.
Right.
That's one procedure that we can do. But I've noticed that sometimes that ligament is so thick that the success rate for the spacer is not as high. So what I do is I do this procedure with this device here under strict X-ray guidance, precision X-ray guidance, the mild. What I do is, if you notice how the tip of that works, see the tip?
Yep.
It kind of is like a spatula. This is a little sharp at the point, but it's not sharp enough where you're going to injure any nerves, right? And it kind of scoops right. It goes in right at this level. Now, don't anybody freak out about it because this is very simple. I mean, the incision is not even an incision; it's just a puncture. Yeah. And this goes in, and we go in under X-ray, and we go right over here. Can you see that?
Yeah.
We go right over there, and that's where the ligament is. Now, the ligament protects the spinal canal. any neural structures, it protects it. And it pushes some of the ligament anteriorly so it doesn't go through the ligament. You're just decompressing the posterior portion of the ligament. And this has proven, and this has been around for probably 20 years or maybe a little less, but this has proven that you don't need to take a lot of ligament out to get good relief.
Right.
Sometimes a ligament is so big that this is just not enough.
Right.
And sometimes the ligament is so big, a spacer is just not enough. And sometimes it's so bad that the patient might need, major surgery.
Right.
Very far and few between with these two different procedures. So when I see a patient with a very thick ligament, I tell them right from the beginning, you've never had any treatment, maybe epidural is going to work, because sometimes they, believe it or not, with a thick ligament, they work.
Yeah.
So that means you can't deny them an epidural.
I've been on the patient side of the waiting room and just talking to people. And I've talked to people, all I get is a shot, and then I don't have to see them forever. And I always used to shake my head and wonder, because I wish I was that kind of guy.
I got patients come in with such thick ligaments and such bad spinal stenosis. They have no walker, no cane, and they walk without a problem. They came in because they got a shoulder pain.
Right.
Or they got some arthritis in their back. And I look and I said, how the hell are you walking? I call them a phenomena.
Right.
Really a phenomena. And then if they have some low back pain, I give them a little injection and it goes away for a year.
Yeah.
What's better than that, right?
Yeah, that's amazing to me.
But when they have problems and the epidurals don't work, I put them through, and they got a thick ligament. I do the mild procedure, and believe it or not, some of them I do the mild procedure too, and they don't need the spacer anymore.
Yeah.
But the majority of them might need the spacer. And then I put the spacer in, and they're good.
Right.
It might not be good if they got multiple levels unless I do all the levels.
We got Ron here. He says, your best pain doctor.
Ronnie, how you doing? I just had one of your patients the other day. Thanks for sending them over. Actually, it was a patient that they happened to tell, I can't remember her name, but they happened to tell you that they had this pain doctor they're going to go see to take care of the spinal stenosis, and mentioned, and you asked who it was, and when they told you, say, he's the best pain doctor. And I appreciate that. Thanks, Ron.
Yeah.
Anyway, now, here is the best of the best, the procedure that I have mastered over the years. It's the endoscopic guide decompression of the central canal neuroforamina.
Yeah.
And what it does is a patient who has sciatica pain, a patient who has spinal stenosis. I used to do this for spinal stenosis, but I have cut back a lot of it because of the new procedure that we just talked about. But I did a drawing here. When I started college, I wanted to be an artist, and that was my goal. Then I decided not to be an artist,
right?
And I decided to become a doctor. And that's a story which, if you go back in the archives, you can hear that story. Maybe one day I'll repeat it. But
yeah, that's true.
So I like to, if I have time, I like to draw pictures and use visual aids to make it easy for my patients. This is a drawing that I made of where you got the spine, right? And in the spine, you have the nerve, which is right there, right? Which comes out, and you can see it red. Why is it red? Because it is being pinched by this bulging disc. This bulging disc is a herniated disc, protruding disc, extruded disc, whatever you want to call it. It's pushing this nerve right up against this bone. You see these bone spurs in here?
Yeah.
That causes sciatica pain.
Like little teeth.
Yeah. You give them epidurals, and it's right there. Here's a picture of one right here. Here's a herniation right there.
Right.
And then the nerve goes right in between here, right in between that and the bone, and it gets pinched, just like it is in the picture.
Sandwiched.
Yeah.
Between the two.
And it depends how bad it is. Now, what I do is, if you see right here, it's about 4 or 5 millimeters. That's the incision. And I go in there with a scope, and And if you see this picture, you can actually see the scope right here. And I traced that scope just to show you how small it is. It's an 8mm scope, which, by the way, you're putting it in a 5mm incision. It sounds like it wouldn't fit, but it does. Stretches the skin, and it doesn't hurt the skin. And it pops through there, and I go right down to this area. Now, you can see right there, you can see a dark spot, and you can see the instrument grabbing the herniation there. See the herniation there, pinching it there?
Yeah.
I grab that, and I pull it out through this hole here, right? Once I pull it out through the hole, you no longer have a herniation there. The nerve is perfectly free on that side.
Right.
It can take up to 20 minutes to do this. I mean, it's a very good, it could take a few hours depending on the scar tissue, if you had surgery before, how many bone spurs, how tight it is, how big, how many herniations. And you see these bone spurs rubbing up against that nerve?
Yeah.
I trim those down. You can see I got a little instrument there, a hand reamer,
Yeah.
a hand reamer, and I trim it down. A lot of these bones are not that hard, but they're hard enough to put pressure on the nerve and hurt. So I put the reamer in there. I could use a shaver, I could use a drill, a shrill, whatever you want to call it, and I could hone that down like a Dremel, right? I hone it down, and once I do that, the nerve is perfectly free, and the pain is gone from that nerve. We find interventional pain docs, we find the pain generator.
Yeah.
We get it out, and the pain goes away.
When I first came and I needed this procedure, I had this done, and you were teaching me with this very same artwork that you made, and it's a beautiful thing because it makes you really understand what you got ahead of you. You know,
we give a pamphlet on this. If anybody has a problem like this, you can call the office. We can send you the brochure. I have everything on it in this folder that has. I've done a bunch of articles, retrospective studies in my cases, probably about 10 years ago. We should do some more. I just don't have time or the ability to do that right now. But these articles are in there, and they had to be approved by professionals, my peers, in order for it to get published, and they were. So, and it's a proven, and this is, and I'll say it again, this is what I always say. This country, when it comes to spine surgery, is the most backward country in the world because they're not paying for this procedure. They're paying big money for big surgeries.
Right.
And when you need big surgery, you need it. When you don't, you don't. And nobody wants to do this because you don't get paid for it. I actually have to pay, I have to charge a patient in order to do it. I mean, I get paid a little bit of money, but not enough money to pay for my overhead. So I pay, and it's almost like break even.
Right.
I mean, it's not even worth. It's not even worth. We're in a dead end street here. We got the cops.
I know.
Hope they're not coming from my 1940 Ford parked in the parking lot.
Oh, is that what you brought? Yeah.
Oh, that's the probably Santa Claus.
Yeah. Oh, maybe. Yeah.
It's probably the fire trucks coming in with Santa Claus.
Yeah.
Anyway, so that's the problem. It's all political, and hopefully one day it goes away, and we'll all be doing it again. And the doctors will love to do it. The surgeons, I'm sure, love to do it. There's a lot of surgeons that I've taught how to do it, and they say, I wish I could do that all the time.
Right.
But they can't pay their overhead. You can't even pay. As a spine surgeon, including myself, it's hard to pay for your malpractice insurance because as soon as you start doing spine surgery, it goes up astronomically, you know? Anyway, that's what it is. Anything else you want to talk about? Anybody want to talk about?
No, we got
Connie, you got anything to talk about?
She says, good morning, Dr. Jasper. You sure have helped me.
Well, thank you, Connie. And I appreciate you guys watching. I guess we put it on Facebook today, and I've shared it, so a lot more people are watching.
Yeah, I put it up on Facebook yesterday, so more people would get a chance to hear it.
Yeah, and I can't figure out how to, from where you put it on, to share it on my personal Facebook.
Oh, all right,
I got to figure that out.
Yeah.
Anyway, so we talked about epidurals, radio frequency ablation of the medial branch nerves for arthritis. We talked about basal vertebral nerve ablation for vertebrogenic pain. We talked about kyphoplasty for compression fractures. We talked about spinal stenosis, Minuteman for spacers. We talked about mild procedure for a very thick ligament as a and you can do that, a mild procedure, even if you don't ever plan on doing a spacer.
Right.
And it's just that might be enough. But
And then
let's talk about, and we talked about endoscopic surgery. Now, the biggest problem that I have in my office these days, what time is it? We doing good?
it's 11:03.
Oh, is Barbara here?
Barbara? She's here.
Barbara's here. We're running late. I guess you're not going to hear my crap about, real quick, I just want to tell you, I just want to go over something very simple. I hope Barbara doesn't mind. I want to compare Medicare with an Advantage program. Real quick.
That's right, yeah.
Medicare Advantage. What do? Medicare has a Part A, B, and D. Part A is hospitalization. Part B is the ability to go to a doctor.
Right.
And Part D, drugs. You have the same thing in Advantage. And they try to tell you, come on in, Dr. Schneider. I just want, and you probably agree. Dr. Schneider said, I'm going a little bit into her thing, but we got plenty. Everybody's easy going around here. I just want to put a little bit in here about this Advantage because I came a little late.
It's a disadvantage.
Yeah, I had to get some visual aids at the office, but I got about 5 minutes of this. But what you got to understand, the major problem with the Advantage programs is it's a managed company. It's insurance. It's like an HMO. Right. They call them PPOs sometimes. But the point is, they manage your pain. They manage your treatment. It's no longer in the hands of you or your patient or the patient.
Right.
It's not in your hands. It's not in your doctor's hands. Everything has to be approved. Everything. Medicare, there's no complications.
Yeah.
There's no, I listened to some YouTube videos. There's a guy that says, with Medicare, there's no compromise, right? They don't ask any questions. They pay. And what's good about Medicare, you can go to, if a doctor, and most doctors do accept it.
Yeah.
You could go to any doctor in the United States, but you can't go to any doctor with a disadvantage program, an advantage program, because you got to go into their doctors of their network.
Right.
And if you go to any doctor with Medicare, you don't pay any co-pays, you don't pay any co-insurance, you don't pay any deductibles. But guess what? People don't know, and they don't tell you because they're selling these insurance companies. The brokers are selling these insurance companies. The agents are selling them to you because they're making money.
Yeah.
One guy was telling, there's one guy on the YouTube video who goes, one of the biggest Medicare conferences that teach the agents all about what they're supposed to tell these and how they sell the Medicare with a supplement or Medicare Disadvantage or Medicare Advantage. And they asked how many sell more Advantage, and they all raise their hands.
Yeah.
All raise their hands. They say, okay, how many of you out there that need to choose between Medicare and Medicare Advantage would buy Medicare over Medicare Advantage? They all raise their hands. So that's got to tell you something.
Yeah.
And then when you hear these companies on TV trying to sell Medicare Disadvantage, and they tell you it may pay for your dental, may pay for your eyes, and it may even give you money back in your Social Security check. What does that mean? It may not, and most likely will not. It goes on and on and on. And my main thing when I talk to these patients, and I say, why don't you want to get Medicare? And they say, because I can't afford it, which is true, but there's a loophole. When you have Medicare, Part A, Part B, you pay $175 a month. When you have Medicare Disadvantage, you don't pay anything for A. B, you think you're not paying, but they're taking it out of your Social Security check. So you're paying that anyway.
Right.
People don't know that. I didn't know that until I listened to a YouTube video today. Thank God I learned how to do all my surgeries on YouTube. No, I'm just kidding. Because I believe everything you hear on the internet.
Right.
But anyway, now if you want to get a Part D, which is drugs, you don't pay for it. You don't pay for it with Medicare Advantage, but you might pay anywhere from 15 cents for Part D for Medicare to maybe $150 a month, right?
It depends on the plan.
It
just looked into it.
Yeah, it depends on the plan. I'm just talking in general.
Yeah.
This is nationwide. However, you try to get this free medication with Medicare Advantage, and they deny it. So now what do? You got to pay out of pocket. Medicare doesn't deny it. They tell you, well, you know what, you can't get this one because it's made. It's the first. You got to get a generic. All right, but you get the medicine. And then to conclude this, as far as money goes, most Medicare Advantage programs say you don't have to pay anything, even co-pays and co-insurance like that. But you got to pay extra money for that. But Medicare, if you have a catastrophic problem, the most you ever pay in 1 year is $4,000. The average is like $4,136. If you are Medicare Advantage and you have nothing wrong with you, you're 65 years old, you're perfect health, you might go another 10 years with not having any medical problems, you might pay $2,000 a year. But God forbid something bad happens. You could pay up to $10,946 because of all copays and from the hospital, from the doctors, from the co-insurance, the deductibles. So you're talking, and who over 65 has nothing wrong with them? Who over 75 has nothing wrong with them?
Right.
So it's the Medicare disadvantage. And that being said, we'll get more into it another day.
Yeah.
Oh, one more thing. People tell me it's too late. You can't do it because you passed the enrollment period, December 7th. No, there's another enrollment period between January and March.
Really?
Nobody knows that.
Me neither.
I believe it because I heard it on the internet.
Right.
But the catch is, Dr. Schneider, the catch is that, and this is how they get you. They get you this way. If you choose to go into Advantage program when you turn 65, you got like a 6 months to a year period that you say, I don't like this. And you can go directly into Medicare, no questions asked. But if you're in a disadvantage or you're in Medicare and somebody sells you a disadvantage program and you're in it for 6 months to a year, whatever it is, now you want to go back into a Medicare program, Medicare, sure, you can have it. You deserve it because you paid into it. But now you got to get a secondary. And the secondaries are the traditional insurance, Blue Cross Blue Shield, United Healthcare, Aetna, whoever else there is out there. You have to get a underwriter, and you got to get an insurance physical. You got to get all your history has to be done. Whereas before, when you turn 65, you're not obligated. They give it to you. But now, most people, what they're doing is they realize that Medicare Advantage is not paying for everything, and they're sick, and they need more. So they go into Medicare, and the insurance company say, hey, listen, I'm not going to take you, the secondary. We're going to deny you because you're too sick.
Oh, I didn't know that.
That's something I heard on YouTube.
Right.
I believe everything I feel. All right, everybody. Thank you very much. So you better think twice before you go into Medicare Advantage.
Yeah.
Have a nice weekend.
Okay, for more information about Dr. Gabriele Jasper and all the things we talk about, please go to jaspermd.com. And to make an appointment with the doc, or you can call 732-262-0700. Coming up is Dr. Barbara Schneider, where Radio Free America, where the truth